is I'm going to spend a little bit of time talking about some of the family dynamics and adjustment issues. I actually, during the break, got a couple of questions I'd like to respond to that some other people might be interested in. And what we're going to essentially lead into from this point forward is drawing some of these things together, talking about some issues, but this is where we really want to start to hear from you. We want to know what you are interested in. We're going to move into extended questions and answers, family situations. And so we have provided a base, a knowledge base, and some recommendations from where we started this morning to this point. But we want to now build on that base and make it what is most of interest to you. During the break, somebody came up and was asking a couple situations that I wanted to respond to that relates to neuropsychological evaluations. And a situation would actually, I find a lot in an affluent population. The basic question, there are two questions. One is, first of all, what do you do with a family member who has a very high baseline IQ and you, as a family member, are seeing some changes, but, you know, they're bright enough and they have enough cognitive reserve still that they do a decent clock drawing and they pass the mini mental status exam in the doctor's office pretty well, and they basically, according to all the norms, are doing fine. And something that we'll talk about is, and so the physician says, oh, they're fine. You know, I did a mini mental status and, you know, they got a 30 and this and that and they're okay. And you say, well, I don't know, Dad's doing this and that. Oh, no, they're fine. You know, it's just age. Well, one of the things that this really touches on is if you have a high baseline level of intelligence, you have to burn through and be really impaired for a decent period of time to beginning to drop below the norms on these screening tests. These are cognitive screening tests in a physician's office with a primary care physician or general internist designed for people with an average IQ in the population. And so the recommendation I talk about is this is a situation where you need to get what's called a neuropsychological evaluation. Family member has to go to a neuropsychologist, to a center or something like that, because a neuropsychologist like me has norms and tests which are designed for people of high IQ. And there are ways in a detailed assessment to be able to see the deficits long before it's going to show up on a screening test. And so if your gut's telling you something's going on, maybe, maybe not, they've been diagnosed with mild cognitive impairment, which actually probably means that they may have had an evaluation. But if your gut's telling you there's something going on, go to a neuropsychologist and get an assessment done. They can look at that top, 1%, 2% of IQ and tell you whether or not actually something is beginning to occur. You probably have seen
Agreed.
this. Yeah.
Agreed.
I'm just hoping I'm in the 1 or 2%.
Yes, yes. We'll do some neuropsych eval on you later on. It's okay. We all have had that word finding problem today. A bigger and more common question, and this comes up a lot, and I have to tell you, when I was doing neuropsych evals before, I don't really do it so much anymore. But one of the things about Alzheimer's disease and the nature of what's going on, and I would see this from actually physicians themselves a fair amount, which is like, well, why do you want to get an assessment? So they're going to tell you that Dad has Alzheimer's. There's nothing you can do about it. Leave it well enough alone. Why do you need to know? There's nothing you can do about it. So just, do the best that you can. And family members will be told this by medical personnel in their helplessness and their hopelessness. And it would, actually the question would come to me, and I have to tell you how I responded and why I'm not going to use the word enjoyed doing dementia evaluations, but why I felt good and useful about it, which is, remember that S-shaped curve? If you can actually catch it early, what I found and what I would say, because I would sit there and I would tell people the diagnosis. I would say, actually, this is consistent with Alzheimer's disease. And I had people crying in my office and very upset. That's the other thing. It's like, well, why do you need to make Dad upset? What I would tell people is, because we are talking about this now and early, you still are going to be able to be a participant and a collaborator in what happens to you. That instead of having people make decisions about you when you are far enough gone, yes, this is unfortunate. It's tragic in some ways. But you know, this is your life, and you still are able to participate in things about you, and you're going to be able to help design what happens and what you want. And again and again and again, people said, thank you, you're right. This is what I would want. And this is what the physician, the primary care physician, was not thinking of. All they were thinking of is well, what are you going to do about it? Well, actually, there's a lot you can do about it related to decision-making in your own life. And that's why you get the evaluation. Finally, at lunch, we had a great conversation, and we're talking about how many of the things we're talking about today you're having to be reactive. An event is occurring that you have to react to and deal with, versus being proactive. And that for many people, being proactive is better. But you know, part of what we also deal with is that for many families and many individuals, being proactive is hard. It means speaking up. It means having crucial conversations and being brave to talk about things. And a lot of families do not have a history of communication. I work with multi-generational families of wealth and advocate for family communication. But the fact is that it requires brave conversations to approach somebody and say, can we talk about this, that, and the other thing? And I would encourage you to look inside yourselves, think about your family, and the idea of, you know, face your anxieties and face having these difficult conversations, even if the family does not have a history of doing so. Would you guys agree on that?
Oh, yeah.
Yep.
And it does take courage, but in the long run, it will be worth it. And, you know, it's okay to cry. It's okay to say, I don't know what to do. I don't know what the answers are, because you'll figure them out.
Yes.
And this concept of involving the person in their own future is extraordinarily powerful message, and I'm glad it came out. You said it very, very well. Just from a lawyer standpoint, if I was that person and I knew that, someone says, well, you're in dementia, what it would mean was I would go out and I would think about my healthcare surrogate, right? We talked about that, and we talked about doing that. I might even have one, but now it's a little different. Now it's not just some abstract, I got to sign that off. Okay. Now it's really going to happen, and I'm going to have to sit down with that agent, talk about what happens to me. And I'll give you one other interesting example. So you were talking about you don't want a feeding tube. Well, that's an easy one. No, you shouldn't want a feeding tube. If you learn nothing else, don't ever put a feeding tube in someone if you can avoid it. There are rare circumstances, but not as a matter of course. The other one is you want to be fed by hand when you forget how to swallow. Sounds like a grim thing, but eventually you get far enough into dementia, you won't eat, not because we don't know if you're hungry or not, but we know you've forgotten how to swallow. You can be, and you will go to nursing homes and you will see it's typically wives feeding their husband in the nursing home because he won't eat on his own, being hand-fed. Well, you may or may not want to be hand-fed, because one of the ways your body, probably the best way, one of the better ways to die is to die from lack of nutrition, not hydration. That's not a good way to go, but nutrition, right? And so if you don't eat and you have severe dementia, remember now, you're pretty untuned to what's going on. It's a little spotty at best. Maybe dying from not eating is better than keeping going more and more deep into dementia. And maybe your wife needs to know that so she knows that she's not doing the wrong thing by not hand feeding you, that you don't want that. Or flip it around, you believe for whatever reason that is impaired, you should do that. Make sure people know that, right? That's the kind of decisions you can make if you know in advance.
I don't know if you're aware of this, but you actually just described a situation that's a court case in Canada.
Okay, no, but I know these.
And let's describe it, because one of the things that's going to be the theme from this point through the end of the event is dealing with ambiguity. All the shades of gray and uncertainty and ambiguity and what it's really like as you struggle with all this. And there's a court case that has just gone on and actually been ruled on in Canada, where they're going through a lot of stuff about right to die and assisted suicide versus not. And I'm a member of STEP, or international organization about trust and estates and some other things, and this came up. A woman made her expressed wishes written down with her agent, saying that if she were to get into dementia and end of life, that she did not want to be fed. Well, for a variety of reasons that I forget right now, she has wound up in a nursing home. I think that there was another caregiver involved. And she's in a nursing home, and she is one of those kind of passive, compliant, quietly dementing people. And if you sit in front of her and feed her, you go like that, she'll open her mouth, and she'll be fed, and she'll smile, and she'll take the food. And the daughter, who is the original agent, who said, excuse me, she had expressed wishes that she is not to be fed, is fighting with, I believe, the other daughter and the facility, who says, but wait a minute, she clearly is compliant with eating. If you spoon feed her and give her food, she doesn't say, no, I don't want it. She doesn't reject it. She seems quite happy with it. And so we're going to honor those wishes. We're going to feed her. And the other daughter took them to court. Well, the Supreme Court has ruled that if somebody complies with being fed and is okay with it and does not seem to be fighting it, then you need to honor their wishes at that time. And they voided her choice when she was more intact mind to say, by the time I get to that point, please stop. And I think we need to keep up on these sorts of things, because the idea of what will prevail in all the strange circumstances that will come up is part of what we all have to deal with. So,
Well, it's another example, as if that, and we repeatedly find this, that the wishes of the individual in their personal care and health care are much less important than the wishes of the next generation or their spouses. And courts and providers and whoever are much, you've got a demented person who years ago said X or Y, and you have a younger person, let's say an adult child, probably a daughter, saying, I want to do X and Y, despite what Mom said, X and Y will happen. You can't, it's almost impossible to override the living wishes vis-a-vis the people who are near death or severely demented. Now, okay, that's just a reality. And there was a wonderful study here at the intensive care ward in Chicago by 6 months by a sociologist in finding how little living wills and powers of attorney, living wills, advance directives, how little effect they had on anybody. Yeah. Advance directives. Everyone just ignored them, doctors, everybody else. So I think that goes to what you're kind of getting into here, of course, is how do you talk to families so increase the chance that you won't have two daughters fighting about your care?
Yeah.
Or that your wishes on your health care, albeit admittedly it's hard to predict exactly what's happening, nevertheless, you have a better chance of what you want happening, right? That's part of the main issue.
I think, what the message is, which I just mentioned a few minutes ago, which is in some ways the hardest thing for individuals and couples, which is communication. Within a generation, across generations, within siblings, families differ a lot in communication, particularly communication around areas that they have differences in. And being able to approach those conversations and work it out is part of our recommendation to you in what we're going to do.
But even when you have those conversations and you talk about them, I have a patient that had a significant neurologic condition, was still alert and oriented, knew within the next few months he was not going to be, he would not be able to swallow, he would not be able to function, he would be bedridden. Extensive conversation with him, his wife, and his son. Clearly articulated what he wanted: no feeding tube, no vent, no heroic measures. 2 years later, I get a call from the facility and the physician wanting to know, the family wants to know why I was allowing him to kill himself. They all sat at the table. We talked. We talked about what he wanted, why he wanted it. They agreed. I explained to them what the pathophysiology was going to be like and what was going to happen to him. When it comes down to the point of, and shame on us as healthcare providers, a physician walking to you and saying, you understand if your mother doesn't eat, she will starve to death. You do understand that, and you still want to do that. Am I correct? Which one of us has the courage to say, oh yeah, go ahead, starve my mom to death, as if we don't have enough guilt that we're carrying around with it anyway?
Well, actually, I'm going to tell you a story from 2 weeks ago where I was in that position. Remember I told you about my little mother? I think she's like 4'10", I think. Maybe 4'9". She might have lost a little bit. She and I always had a pretty good relationship, our ups and downs. I'm sort of the designated responsible person. I'm healthcare proxy. I'm DPOA. I'm trustee, successor trustee on her living trust. And knowing what I know and stuff, we have set everything for years. I knew exactly what to do, and it all worked. I'm like the best situation you could have, and I have all this information or whatever, okay? But my mother had 2 urinary tract infections over the past year or so, and in the second one, last December, she got really sick, acutely confused, went into the hospital, and it was determined that when the time for discharge planning, she went to subacute rehab in the nursing home to be tuned up a little bit, with physical capacity, but it was clear she could not go back to her wonderful independent living facility. And she cognitively really took a big step downward. In going from the subacute rehab, which is skilled nursing facility, she was getting physical therapy and whatever like that. We had team meetings, and whatever the decision was, she had to move to a nursing home unit, and I set her up with a good room and everything like that. Because that's Cleveland and I live in Massachusetts, though, I was not on site to be there every day and whatever. Well, she did not really understand why she didn't go back home because of her cognitive problems. And I have to tell you that the first several phone calls that I had with my mother on the phone were some of the most painful conversations that I've ever had. How many of you remember and saw the movie The Exorcist?
Mm-hmm.
Okay? You remember in the movie The Exorcist, the young priest, Father Damien, and he had his little Greek mother who had deteriorated and fallen apart, and then she died, and he's with the devil. And what does the devil do? The devil plays back his mother's voice to him, saying, "Dear me, why do you do this to me, dear me?" Okay? My name is Jim. It's like, Jimmy, what did I ever do to you? Why am I in this place? I don't need to be here. I'm fine. Why can't I go back like that? Why are you doing this to me? What did I ever do to you? This is on the phone for an hour, like every few days.
That's your mother sending to get you.
Yeah, really. Knowing everything that I know, having worked with clients and patients for years, decades, stuff like that, I still had to be on the phone. Amy, why do you do this to me? And it was very hard. When you're actually put in a situation of being the agent, you have to be prepared to make the hard decisions. 2 weeks ago, I received a phone call from the unit. He said, she's, just want to say it's not an emergency, she's fine, but the doctor came and took a look at your mother and thinks that one of her legs, the diameter of her thigh, one of her legs is larger than the other. And I knew from my medical information that what that means is she may have what's called a deep vein thrombosis, a DVT, building up in the main vein of her leg. Like, you know how they warn you when you take long flights, you got to move around or you can get a blood clot in your leg? Anybody know what happens to that blood clot if it stops being in your leg and decides to go on a trip?
Kills you.
Yeah, it travels up and goes through this side to your lungs, and you have what's called a pulmonary embolus, and it kills you. And so they said, we're taking her to ultrasound, and we're going to look at the leg, find out, and we'll let you know. And my wife and I sat at the kitchen table. And even though it's really clear, my mother's wishes were, if I ever wind up going to Menorah Park, the nursing home side, I don't want you to leave me there any longer than I have to be. I want you, no treatment, no whatever like that, just let me go. And I can do that, whatever. But now I get the phone call. Maybe she's got a DVT. And if she has a DVT, within some period of time, more like hours to days, it's going to go to her lungs and it's going to kill her, which you don't really think about. Like, there's a step in between something happening and then somebody dying. And so the choice was, well, if they say she's got a DVT, do we put her on a blood thinner and we get rid of the clot? And, what would you do?
Depends on her fall risk.
Depends on
Her fall risk.
her fall risk. Okay, so it depends on her fall risk. What else? Any other?
Would it be painful? Are we talking about pain?
Would it be painful? Okay. If you have a PE, a pulmonary embolus, do you suffer when you die? What else? Is the quality of her life going to change from actually this moment until some event? If you give her the blood thinner, is she going to have better quality of life or not? Thank you. Her wishes. Her wishes. Her wishes. She has delegated to me to be her, to judge and decide as she would. As Larry said, you designate an agent in your stead. I am in my mother's stead. What did my mother tell me? If I'm in Menorah Park, don't make me be there any longer than I have to.
Then why is she not on hospice and palliative right now?
Because she has nothing
She
that
could be
will actively
palliative.
kill her. Yeah.
She could be palliative.
I mean, she has, if she were uncomfortable, but,
But
Condition
palliative,
doesn't cause pain, so it's
but
not.
palliative is not hospice.
right,
So basically, she is on palliative.
essentially, yeah.
Okay.
Her wish is what has to guide me, and why I'm telling you this story is when you are given the responsibility to make decisions for someone else. It's a precious responsibility, but it is a difficult responsibility. And you have to be prepared, not just for giving care, but for deciding.
Say she told you that those were her wishes, but she went there and she adapted very well. She was very happy.
Which actually she already has. She's settled in.
And she became very connected to a couple of the caregivers. And she found that the lady in the next room became a good friend of hers. And she actually started to participate to the extent of her ability in some of the events that went on there.
That's right.
She told you something when she knew nothing about what her environment was going to be like. It was just her general outside perception of that's what her life was going to be like and it was going to be zero. But in reality, when she got there, it was much more pleasant and much more amiable than she had ever expected when she was on the outside looking in, not knowing what it was going to be like. So she may have told you, when I go to this care facility, I want to be there as short a time as possible. But as an agent, it's still your responsibility to look at the situation as it exists then.
Yes?
And say, what is really best for my mom within the scope of the power of attorney for healthcare?
Right.
Because she delegated that decision making to me. So it's not black and white.
Absolutely. Thank you. Thank you for saying everything that you just said, because actually, she has settled in. And I have good conversations on her phone. She doesn't berate me anymore. And she doesn't think I'm spawn of the devil. And she has adjusted. And I talk to her, I say, how's it going? I don't say, how's it going on the unit anymore. It's like the place that I live. And yeah, she has adjusted. So what are my choices? What do I do? What would you do?
Again, I'm complaining. I get out there and actually spend some time with them and talk to them just about the situation. They have to do and refresh her memory of what has been stated in those situations. Because when somebody's faced with death, close to death, I've got
Oh, yes.
somebody who's had a spouse who's had a health issue. And I know for
We
years
have the-
he said, forever sick. You know, you've never let me, live like this. And now he's living in a way, and I look at him and I think about those conversations that we've had for many years, and it's different. So that's what I would suggest. Get on a plane and get out there and talk to your mother.
And actually we have, and in fact we're going there this weekend, so I will tell her what you said. Other thoughts?
This all assumes there's cognizance and there can be an informed discussion and conversation. And I'm curious if you're dealing with someone with diminished capacity,
And she does have diminished capacity.
what guides you? And that's just you're in a very difficult, there's no right answer. I still sort of think you're looking at this situation with hindsight and rationalizing the decision because it comforts you, and I still question what her wishes are and whether they were truly honored, if there was any type of medical treatment. And I don't want to.
No, that's okay, actually, because I'm about to throw in another element. We're a reasonably affluent family. My mother was always a saver. I think I may have mentioned my mother and my father were survivors of the Holocaust. So kind of like a depression mentality, but different. And for her, being able to pass on the money that we have to me, my children, I've got grandchildren. Have I told you about my grandchildren? The cutest child. Anyway. And not running down the money is very important. And when we had these discussions several years ago, one of the things she said is, if I wind up in Menora Park, let me go because I don't want to burn through the money. I want you guys to have the money. So, what about that? It's costing $10,700 per month for her to be in Menora Park. And if she were aware of that, she would say, "Oi!" Oh my God. You know? But of course, there is more money, whatever. But what are her wishes from that?
You know her better than anybody else.
I do.
It's your decision, and you have to weigh the pros and cons.
I do.
I might have the exact same sort of circumstances for a parent and was told the exact same thing and make a different decision, and
Yes.
neither of us are right or wrong.
And, yes, sir.
Don't you, at the end of the day, hear me.
Oh,
Yeah. At the end of the day, because it is a balancing and it's all gray, but I think that you've got to weight most highly all the things she told you when she was the most competent.
I will tell you, because we need to move on, that that's the approach I'm taking, which is she may be comfortable, she may be adjusted, but when she had a perspective on how she wanted to end her life, what she said was, because again, she actually is a high IQ individual. She's an introverted individual. Being on a unit like that is a stress to her just because it's an institutional setting. She would much rather be in her own apartment. That every day she is there, and she has said this, she must cope, that she must adjust to the stress of being taken care of by a variety of people, having other people around her who are demented, other stuff that, in a sense, the socialization is actually a stress for her. And my sense, knowing my mother, is she would say, let me go. And I'm going to act consistent with that. I'm sorry?
Isn't she 101?
And she's 101.
She's 101.
Yeah.
Not that you sort of, that there's a cutoff point, but I mean, you can't say, oh my gosh, she was just snatched away from
Right. And I think that,
Hey,
yeah, snatched away at 99. So,
okay, I've got a question for you.
Okay.
A slightly different one. This is one you're going to face. The thrombosis is very dramatic. But here's the question. Do you give a flu shot to someone who's 90 and over with dementia?
Yes.
Because if you don't give them the flu shot and they get the flu, that's a pretty easy way to die.
Well, it could
It's
be a
it's-
painful way to die as well.
Well,
Yes.
but you can
Sepsis and-
mitigate the pain to some extent.
well,
But I mean, the question is, what kind of, and then it goes to the pneumonia issue, of course, infectious diseases. That is, when do we stop, when do we say enough is enough? That if I can get you through this pneumonia, or I don't get you, don't die, because that's how people used to die. They died of pneumonia and flu and other infectious diseases. And now we can push that away. And that's why we have people way over 90 with significant dementia, because we are keeping them, in many cases, we're keeping them alive through infectious diseases. Now, I'm not saying that's wrong, but that's the kind of choice you will face in your own lives with your parents.
I think, and again, we're going to move on some things, but the idea of, you raised a point, which is what should we do or what should people do as policy or consistent with our values? And I'm a big believer that we need to know our values and families need to discuss and know their values for these things. And in this specific situation, for my mother at 101 in Menorah Park, do we give her a flu shot? They asked me, and I said, no, don't give her a flu shot. That to be able to have benchmarks and values and guidelines, moral, ethical guidelines in caregiving is very important and for us to know. And we also need to look at specific situations, and that's part of the difficulty and the tension. So let's look at that. In preparing for the emotional journey of caregiving, you know, there's many things that you guys have to deal with, that we all have to deal with. And living with ambiguity, part of why I wanted to introduce this sort of section and lead us into writing things is, you know, people don't anticipate that these things are generally not clear-cut, that there are multiple perspectives, that there are multiple people who are going to tell you what you should or should not do, including doctors. That there are multiple things that, to be able to make decisions under situations of ambiguity, when there's a lack of clarity on all these different things, when everybody's got an opinion or a truth in their values of what should be done, and that in fact even professional expertise may vary depending upon who you're talking with some of the caregivers and doctors. You know, there's a lot of things in studies looking at what doctors do. For example, doctors will either comply with or advocate for much more care in end-of-life situations than they will do for themselves. There's a great study that presented case studies to physicians and said, you know, if you have cancer and it's this type and whatever, and the physician knew everything about the treatment, you say, what would you do with your patient? They'll say, oh, we'd keep going with it like that. If this were yourself, what do you go? Oh, I'd stop. Because they know what's going on. But I also have to say, and one of the themes that we're going to mention is doctors themselves have strong values and also sometimes concerned about liability. They have beliefs about many things. And that you're also contending with the healthcare system and its way of doing and enforcing what they would like to do. It's a matter of living with complexity and not simplicity. That the idea of being a caregiver means dealing with multiple factors, often that are moving at once and changing at various times. That sometimes patterns emerge which are clearer when you look back in hindsight. Remember that first part of the curve? I mean, that's a period of ambiguity and uncertainty, and sometimes it's only when you're starting to go like this that you look back and say, actually, you know, this has been going on for 4 years. But while you're living it, it's often really hard. And there's the complexities about relationships within families and the family dynamics. We have a question that came up, submitted during the break, that I'm going to simplify, that basically says, this is a person in a situation of multiple siblings with parents. The two parents and one sibling, who it seems are most closely together, are highly aligned, and they're not being rational regarding the limits of the spouse to care for the parent. Person submitting the question says basically, you know, the daughter and the other spouse and parent are driving the bus without considering the concerns of the rest of the family. What can we do? You know, and one of my senses about this kind of question is, in families, sometimes we're not talking about the person who has the power. We're talking about a person who actually doesn't have the power and who may feel powerless. And you are in situations of helplessness and powerlessness to see what goes on. And sometimes when people are in positions of powerlessness, they decide they're going to take it to the courts. And Larry, that's where you run into things in your profession. The legal profession sees it. That people litigate these things when they feel powerless or something should be done. Living with limits on your sense of control. How many people here feel much more comfortable when you feel like you're in control? All right. I was looking to see, does anybody not raise your hand? You know, we're all used to being pretty much in control or wanting to be in control. And one of the things about caregiving is there are big times when actually you're not in great control of what's going on. And a lot of us don't tolerate that very well. And how we deal with that. That there are legal issues, again, in terms of whether you actually have power to enforce things. There are medical factors, financial factors, the relationship factors that, you know, caregiving often involves people feeling like your hands are tied. And a lot of us don't handle that really well. You may have, and there are personal issues with decision-making and you know, emotional reactivity under situations like this. One of the things I want to mention that I have to admit a bias, and it's funny because I was in the healthcare system. I was a clinical neuropsychologist for many years, and not just as like an outside private practice. I was embedded in medical systems. And I have to tell you that a lot of physicians struggle with this sort of stuff, but because we're talking about affluent clients, I have to tell you something else that's a reality, which is that many physicians don't like rich people. Many physicians have biases about the wealthy. And I've had several situations, including one I can think of in particular, related to an institution you would not imagine, which was the Mayo Clinic. The Mayo Clinic sees a great many affluent people. But I've had situations in which children were concerned about a parent who was starting to have dementia, significant wealth in the family. In this particular case I'm thinking of, it was greater than $50 million. And there were 3 daughters, and one of the daughters approached the primary care physician who had known the business owner for many, many years. And in a conversation in the office visit, the guy seemed fine, and the primary care physician basically thought and wrote in the medical record that the daughter was trying to get the dad's money and that we should be very careful about complying or collaborating with this daughter because I suspect that it's just all about the money. And I was a consultant to the family in a variety of ways, and I knew that the father was starting to have dementia. And it took a lot to basically eventually end run that physician and go to the neurology department and get him a neuropsych eval that did diagnose questionable mild cognitive impairment. But I've seen that again and again and again. They think that this is all about fighting over money. Sometimes it is. But it's amazing how many physicians I've seen who basically have a lot of stereotypes that if there's money in the family, that's always just what it's about. And they don't see legitimate concern. So, recommendations. First of all, if you're in a caregiving situation, you need to make room in your life for it. You cannot just layer this on to all the other work and home and this you have to do. That you're going to be much better off in handling the stress if you make room for it. That you have to make room and get support around you in terms of emotional and social support. If you can, find positive family support. My wife actually comes from a family of 7, and when her mother had a stroke about a year ago, we were all standing around in the hospital room, and there was great consensus among all the kids, and the physician came in and asked, well, what do you want to do this, what do you want to do that? And basically it was to not do a lot of treatment, let her mother go. She died 2 days later. But one of the things that the healthcare team commented on was how great it was to deal with a family that was together. There are peer networks and groups, including increasingly social media and faith organizations. Church, temple, spiritual organizations are a great source of support. And as you've heard us say repeatedly today, get a good professional team in place, which can be hard. Medical professionals, you may need somebody who knows neuropsych. I think geriatric care managers are like, gold, that they've done more great things for people than just about anybody else I've seen on a team. But if you don't have a good team in place, get a good team in place. Be willing to spend reasonably to help reduce stress. And by that, what I mean is this is a time to use the resources of the family on behalf of the family. And it's hard to know how long things are going to last, whatever, but to pay a little up for better air travel, to be able to be more comfortable when you go visit in a hotel, to be able to spend a little bit more money, to be able to rest and relax is money well spent. People try and skimp sometimes because they feel guilty or other things. And what I've seen is those people who understand you need to take care of yourself often do better. Inside you, be guided by your values, number 1. Think about, talk, share, figure out what are your values around some of the things that we have touched on today. Values are your guideposts, and if you don't know what your own values are, or the values of the family, it's much harder to make many of these hard decisions. Dedicate yourself to learn as much as you can about, here today, for example, the kinds of things that will educate you and help you make some of the choices that you have to make. On one hand, as Marty in particular has been very good about talking about, be assertive and advocate for your elder and yourself. Speak up. Be an advocate. At the same time, having skills to negotiate and collaborate with the important people involved with the person you're caring for are very important. I've seen a lot of people think advocacy means being aggressive and pounding the table always for somebody's needs. Yes?
Do you have any suggestions on how you bring in some siblings who are
I can give you a short answer on that, but maybe we could talk more. Any suggestions for how to bring in siblings and to collaborate with siblings? Because collaboration within the family, not just with the team, is important. I could give you an easy answer of do the best that you can. But what I can tell you is there anybody in the room here who knows what's called interest-based negotiation or principled negotiation? Gary knows in the back. There is a thing, and it's worth reading about. Interest-based negotiation focuses on the fact that in most of the time when we have conflicts, there's our interests. What do we want to have happen? And then there are our positions or our methods, which is how do we want to have it happen. Interest-based negotiation, which is actually the foundation currently for all the wonderful new advances in diplomacy that we have, focuses on what is it that is your main interest in what happens. Because within families, often people share certain interests. What they are fighting over are the positions or the methods about it. Let me say that again. Interest is that mom be comfortable. That's an interest. A position is, and so she should be at home. Do you see the difference? That's a method or a position about the interest. Very often, most often, people fight over positions and the methods by which something should be accomplished. But they actually share common interests, or they have interests which are not incompatible. Sitting down and calmly trying about and asking, well, what is it about that that's important to you? Well, I want mom to be comfortable. I want mom to be respected. You say, well, actually, I agree. I want mom to be comfortable and respected too. Sometimes getting to the interests that people share is a way to defuse conflict. And I would encourage you all, there's the Harvard program on negotiation, PON, and Getting to Yes was a book that was written about that.
The question was slightly different as I heard it, but so I'll change it. He said, how do you get, I believe you said, how do you get siblings who are not so involved to come into the decision and get more involved, right? Is that?
To be more involved?
Yeah.
Okay.
And that's an interesting problem because if you, and you can correct me on this,
Go ahead.
but what you see, because you see family disharmony, sometimes it ends up in the courts. You have some siblings who just emotionally are not going to get involved, can't. They're protecting themselves for some reason. Emotionally, they just can't do it. And my wife comes from a family of 6, and when her mother was dying of cancer, it was obvious that the different children, each one had a different position as how close they could approach this problem and what they could do with it. And as you said earlier, or as you said, you can't change people. They're not going to come around and become new people. So maybe you have to accept the fact that you're the one that can handle the stress, the emotion, the problem, and stay closer to the issue. Maybe that brother or sister who just seems to be inexplicably not dealing with it is really, they can't. The pain's too great for them. That's the easy answer, which is say do nothing. But what we see on the other hand, though, is sometimes these people will stay away until right at the end they come rushing in the door and say, "What are you doing?"
Right.
You want to take it away when that happens?
Well, trying to prevent that is a good thing, but the idea of what roles can people have is a way to kind of reframe it. Some people do not want a role in caregiving. Some people are afraid of the feelings or can struggle with the feelings, and frankly, you may need to respect that. But sometimes asking siblings, what role would you like to play, or do you think you can play, may open the door to talking about ways that they can offset or offload certain things that are manageable. And maybe there's a way to then, have them have a role. Because the risk is if they can have no role, then they come in and they want to take over the main role. In looking, because I want to move on here, one of the things that I most want to emphasize is, in addition to taking care of yourself and that resilience is more important than perfection, is tolerating ambiguity and helplessness, which is part of what we've talked about throughout the day, but particularly I wanted to show you with some examples, like with my mother, which is understanding your own limits, tolerating the fact that you have to deal in ambiguity, and realizing that this is a situation where you do the best that you can, control what you can, and then let the rest go. Sometimes can save your sanity and make you survive to make it through what needs to be done. So with that, and it's funny, I have a little thing. By the way, therapy, there's actually studies done, interestingly, accept medication if possible. Antidepressants during a period of extreme stress and caregiving can be extremely helpful. You need to stay in the game. If you fall apart, like they say in airplanes, put your mask on in order to help somebody else. If you fall apart, it does nobody any good. And so do what you need to do, including therapy and medication, if it's going to keep you managing the stress and surviving. So with that, now let's see what thoughts you have. And
One more, I want to just interject.
go ahead.
It just takes you to the next step. Assuming that you find yourself in a family disharmony situation about the parental care, and it's gotten a little mean-spirited, and it doesn't seem to be you can get out of it. You've tried. And maybe someone's even threatening to sue or something like that. There is family mediation. There are family mediation services available. People you can go to who sometimes are brought in after a lawsuit commences and the court says, this is a family squabble, I won't hear the case until you've tried to mediate this. But you can actually bring a mediator in without a lawsuit.
Yeah.
It's not, and these people will help you do exactly what you're talking about. They will help people identify their interests and what methodologies different methodologies can obscure the fact you have the same interest.
good point.
And a family mediator can be very, very helpful. Among other things, they allow everyone to vent, you included, because that's the wrong person, you know that. You're the one, they're crazy, you're fine. And so you're just getting that off your chest is good. But more importantly, after you've all gotten done venting, maybe then you can start moving towards some progress on the real problem, which is your parent who needs some help, and how can that be best delivered. So family mediation is a possibility if you find yourself careening towards litigation, and trust me, you don't want litigation.
Yeah.
Okay, so what questions?
No, what are some of the things that today has evoked for you, and how can we be of help to you in thinking about some of the situations perhaps that you are in?
Hold on, we're going to ask you just to wait every time until a mic comes, okay?
There we go.
Okay. I'm one of 8 children.
Closer,
so
closer.
a large family, one of 8 children. And when my father was really sick and the kids couldn't agree on something, and we were at an end of life time. It wasn't like, let's mediate, let's get together. They brought in the ethics director of the hospital to try to help mediate and come to a resolution. Any comments about that is something that's used?
Go ahead.
Go, you first.
What's interesting is more and more hospital systems, larger hospital systems, either have an ethics director, ethics committee. They're also training an ombudsman in situations because of the family strife. But what is also important is, interestingly, Harvard Medical School and some other places have a continuing education program where they are training physicians in delivery of bad news, having crucial conversations, and dealing with end-of-life situations. And we are seeing also a movement to, in a sense, bring back in some of the ethical processes that need to occur in healthcare. So I personally think that it can be very helpful, and they often do work with families. Marty, what do you think?
Ethics committees can be really successful. They can only be a consulting role. So if you have family members, excuse me, that are pulling in opposite directions, they're not necessarily trained in mediation as much as they are in healthcare ethical models. So the family mediator who has those negotiation mediation skills is a good secondary source for you.
The other interesting thing out of studies of intensive care wards and problems of end-of-life care is the passage of time is a great solvent. It solves many problems. It's often, you've got the health, you know what the person wanted, you know, et cetera, so you're going to say no treatment. And then someone else says, we got to keep treating. Legally, you could probably push the issue forward and say, hey, mom appointed me as agent. I know what mom wants. We're going to turn on, wait 48 hours would be my advice. Repeated, these are studies. This isn't personal, but I read the literature. What happens is that often the objector to terminating treatment needs a few more hours to get to where you are already at, for whatever reason. It may just be they need to see the person a little longer, just 24 hours, and then they'll come back and say, I guess you're right after all. But you can avoid a lot of family disharmony and a lot of stress for your doctor, for that matter, by just saying, okay, Tom isn't ready to make that decision. I know legally I could try to push that forward, but let's get back 36 hours from now, 48 hours from now, and see how you feel then. Perhaps in a few hours passage of time, you'll come around. And don't then be lobbying Tom for 48 hours. Let him go and work it out. Let him come to the realization that, well, this is time. And so I really think that's the other thing that they've proven. So if you're in that situation and you have a recalcitrant family member, give them a few hours. You might solve the problem.
Yeah, sometimes time changes things.
Do you see any change in the, oh, sorry.
From what I've read, there's a big shortage of doctors to take care of and specialize in the elderly, gerontologists, and that very few medical schools even offer that as a specialty. What do you think about that, and is it likely to change anytime soon?
Actually, I think it is changing. That more gerontology and focusing on geriatric issues is actually growing in medical education, and there are more people going into it and stuff. So I actually have heard of a trend in which it's increasing. Also, part of what's going on is it typically has been embedded in internal medicine, and it's become a multidisciplinary focus, which is much better. It has psychiatric, medical, ethical, and social work aspects and stuff, and that many gerontologists understand team management and are being trained in being the heads of teams rather than being like the doctor who does everything. And so medical education is actually changing a little bit.
Yeah, they are, but you're absolutely right. They're both on the geropsych side, on the geriatric psychiatry side, there's this huge hole. And, you know, there are gerontologists, physicians that have expertise in geriatric care, but there probably are not enough of them.
We don't have enough.
Yeah,
wow.
the repayment plan, yeah. It's not the high income area necessarily.
Well,
But
we
just
know
wait.
physicians go into healthcare for caring, right? Bottom line is never an impact on your selection of putting stents in
Okay, another
versus.
question.
I'm here to have a position of the aging parent, and I recognize that everybody should have a power of attorney for health care. This, for Illinois residents, this Pulse statement, should seniors have that if they want a do not resuscitate situation? Should they have that in place now, even though the senior may be in fairly good mental and physical condition? Is it like a healthcare power in case of emergency? Or is it something that you wait until you're on the brink of something?
Well, in theory, the pulse is not to be completed until you are nearing terminal needs. However, I use it in my practice as a way to stimulate discussion, just like I would with a do not resuscitate, if you're talking about ventilators and feeding tubes and all the other fancy things that we can do for life support. So I really use it as to stimulate that discussion of healthcare wishes that one has. But in theory, it's supposed to be, you know, for when you have a terminal condition. The problem is that if it's a cognitive issue, then sometimes it doesn't get broached because there may be a 10 to 15 to 20-year lifespan yet before you need the end-of-life discussion. So.
It's not all states, but some states allow an agent to engage the pulse, to create the pulse. That is to create this forum where you sit down with a physician and an agent has been identified. Depends on state law how you identify the agent. But so an agent, for example, you have a demented parent or a demented person who's has got cancer suddenly. And now you have to decide what's the treatment you're going to do for the next few months. Obviously, the patient is beyond informed consent. They are not able to participate in a meaningful way. And so in some states, an agent could sit down with a physician and they would work out a treatment regimen consistent with that patient's prior expressions of how they might, the more generalized expressions, how I want to be treated. That's not possible in all states. But if you have that possibility, let me rephrase this. If you have a parent who is in dementia and has an illness that could be terminal, typically it would be cancer, you should inquire as to whether you could create a pulse for that parent who is apparently not capable of doing it on their own. Because it's a very valuable piece of paperwork and instructions in the form. But it was thought of as end-of-life care decision-making, the patient and the physician sitting down together working on a scheme that would be followed. Because it's understood in many cases with a pulse, you write it today, 4 months later, you're no longer as capable of engaging in that conversation because of the illness. It's, the medications, the pain, who knows. So you need to make the decisions now where you're still capable about future decisions, which you may be incapable of making at that time. So that's the kind of theory. It's like I hope that answers you. I'm sorry if I over-talked.
In Illinois, we don't have an agency pulsed.
Okay, so
if you live in Illinois, that would not be an authentic record.
Okay, that's exactly it. Okay, right here? Right here.
I'm looking back at the very beginning of the day where you talked about the different types of dementia and the MCI and Alzheimer's and the strokes and so forth. I've been under the impression that Alzheimer's really can't be diagnosed before autopsy, or
Strictly speaking, that's correct.
So when we do an assessment, if an assessment is done of a parent, is there, it goes back to the ambiguity, can you really diagnose, or is it being able to just sort of track where they're going progressively? Can they diagnose Alzheimer's in advance?
Essentially what's done is, if it looks like a duck and talks like a duck and quacks and all that stuff, then it's probably a duck. Yes, definitively, it can only be diagnosed upon autopsy, but by and large, most of what's done is a combination of essentially two things. You rule out other causes, and you look at the pattern and the symptoms of what's going on, and if they both match up, there's no other explanation or whatever, and it's got the chronology, it's been going on for 6 years, they're about here, they're showing word finding, memory is worse than other things. If it has all the hallmarks of it, and you don't have any other reasons like B12, other things, then basically the diagnosis is done and you continue to follow along.
And that's why it was senior dementia Alzheimer's type. So it's not
ambiguity there.
So it's not, this is Alzheimer's, this is, and in fact, I suspect most dementias are mixed anyway.
We didn't talk about many other things, for example, Parkinson's disease, and there's a certain kind of dementia that you can get with Parkinson's and other things. remember that there are also commonly a CT scan, sometimes an MRI that's done, blood work. There's a whole medical workup that's part of a dementia assessment. Again, to rule out other things. And then if there's nothing else, and, for example, the neuropsychological evaluation says they're just following straight through, then it's a probable diagnosis.
I would be curious as to your recommendations, having the dialogue with parents that are resisting the discussion or just not aware of their decline. And just to put it in context, I have in-laws. The mother is significantly declining in her cognitive skills. I don't know what kind of dementia she has, but she wouldn't recognize me, her grandkids, et cetera. And the father, who is, the parents are still together, they're in their 80s. The father has impairment too, and they both very much want to be independent, they have resources, and they don't want anyone to intervene. There's 3 sons, they all want to respect the parents' wishes because that's how they were raised, and they want their parents to have dignity. And there are many others that think it's a very dangerous and perilous situation.
Are they living in a house, or where?
They're living in a house, and they are not living where any of their sons or their family live. They live in Denver.
Oh, okay, thank you.
That's very common. I mean, in some ways, that's, I don't know if it's the norm, but it's like, that's extremely common, and your hands are tied until something happens, unless you can talk about it.
If they want to play hardball, and the sons obviously don't, but if they were to want to, what they would have to do is file to be named the guardian of their mother. They won't do that. But that's their only, that's the avenue open, is to have court intervention if that's needed. Now, that raises something we talked about at the break, we haven't talked about yet, which is they shouldn't be living in the house. And this is the biggest gift you can give to your folks. And here's what you do. Memo to self, to be opened at age 70. Sell the house, move into the condo, or get a single-story house. I live in Pittsburgh. Most of our housing stock in the city was pre-World War II. We specialize in 3-story houses and a full basement, and the laundry is always down in the basement.
Sure.
Oh, yeah.
I call them the steps of terror, as you carry the laundry basket down to the basement. Those are not good places to age in place. What you need to do is encourage people to move into housing which is more appropriate for an older person, which is single story, and also closer to goods and services. For example, it's nice to live someplace where you can get a pharmacy to deliver your drugs. It's not, when you need that home care that you so desperately want, maybe it's nice to live near a bus stop where the employees can get to your house. It's hard to get people to come out in the far suburbs to do that kind of personal care. So what is necessary, we have to think about old age, I think it's the 2 moves. You need one move when the post-retirement, but only about 5% of the population leaves their town upon retirement. Off to Florida, see you later. The vast majority of us stay where we are, but that doesn't mean we shouldn't move. It's time now to downsize, to get some kind of a housing or a condo that you really can age in, and that's the big gift you can give, both in the form of the housing and where it's located. So, for example, you're not miles and miles away from a physician, so you can get Uber to pick you up.
Right.
Yes, you want to go. That's if you can get someone as good as Mark, that's what you need. You need to get to that person who can both deliver personal care, but more importantly, coordinate them and identify what would be probable care, right? When you need, and then find it for them.
It's really penetrating the resistance. It's finding a way, a creative way, maintaining their dignity to penetrate that resistance. And there are lots of different avenues that are available. And it really is very individualized.
And actually, that's what you're looking for, which is somebody who can do that. Somebody who works in the field and has some of the techniques and ways of phrasing things or having the conversation that a family member either may not be able to or doesn't want to. And that's part of the expertise of working in this kind of business. We've talked today about there's two main threshold events as everybody gets older: letting go of driving and moving. People don't want to cross either one of those unless they absolutely have to, and even then they don't want to.
My question is, it's the emotional intelligence. I mean, just as you had said that, I said it's emotional intelligence. It's an art. How does one acquire that art, to draw that out of different family members or people and then be able to give it back? I know I said it was an art when I asked the question, but it's special. I mean,
Yeah, no, it's
And
not an answer to my
emotional
comment.
intelligence can be learned, but one has to be open to that, and that's probably the most challenging part of my job is hitting walls of people who don't understand the concept and trying to find creative ways, probably the same as both of you, finding creative ways to thinking critically, thinking out of the box, to analyze the situation and not let your own ego get in the way, because this is not about our egos, it's about the safety of that senior. And that's really drives every decision, the safety of that senior. One kid says they're not safe in there unless they're here, another says they're not safe, and another says here. I become that negotiator. You each have an important element that you're concerned about, but we're talking about the negotiations.
Well, I was just thinking that in a sense the
insight.
siblings would share the interest, which is we want our parents to be safe. That's a great example of that's the interest. But what they'll fight over is the method or the position on how they should be safe. And they say, well, they should stay in their own home. Say, no, they should move. Maybe so staying focused on the common interest and then being able to negotiate ways to look at the position is also part of the art.
I would, about those three sons who had if I was going to talk to one of them, I would say, how much of your, quote, respect of your parents' independence is a flight from responsibility? You want to be, it's a delicate balance. We do want to respect the autonomy of people, but it's easy to say, oh, that's what mom wants, I'll just walk away. And you have to balance those two things, your own desire to run from it or to block it off, right? And the need to respect. And the way I suppose you can get into that, I would say for them is, okay, you want your father and mother want to be left alone, that's good. But let's think about what would happen if X and Y should happen down the line. What would be the appropriate thing to do when things get worse? And they will get worse. So that's one way they can approach it. It's not that we're going to do anything now, but let's be ready for if X happens, and think about X and Y and Z, and there would be different appropriate responses. You may not do them, they may not actually follow up, but at least it'll start moving them away from, I'm shielding myself from this problem, to recognizing at some point autonomy is not the most desirable. Some dependency is there, and we need to deal with it.
I go to wakes, not infrequently, as you might guess. And I had one of the most profound experiences. I was working with a family that had substantial resources. Mom and dad lived in a gated community in Oak Brook. Beautiful home. Mom refused to leave. Dad was a caregiver, absolutely exhausted. 2 kids, both lived out of state. I only had one engagement with them, and it was an hour-and-a-half phone call. Never met mom, never met either one of the kids. I had an hour-and-a-half conversation about Parkinson's disease, what it is, what they could anticipate, what the short, intermediate, and long-term goals were. And I saw this lady's name in the paper several months later and remembered it for some reason and went to her wake. And at her wake, both of her children approached me separately and said, "Oh, you're Marty." And I said, "Oh, yeah." And they said, "Oh, you're Marty." And I said, "Oh, you're Marty." And they said, "Oh, you're Marty." And I said, "Oh, you're Marty." And they said, "Oh, you're Marty." And I said, "Oh, you're Marty." And they said, "Oh, you're Marty." And I said, "Oh, you're Marty." And they said, "Oh, you're Marty." And I said, "Oh, you're Marty." And they said, "Oh, you're Marty." And I said, "Oh, you're Marty." And they said, "Oh, you're Marty." And I said, "Oh, you're Marty." And they said, "Oh, you're Marty." And I said, "Oh, you're Marty." And they said, "Oh, you're Marty." And I said, "Oh, you're Marty." And they said, "Oh, you're Marty." And I said, "Oh, you're Marty." And they said, "Oh, you're Marty." And I said, "Oh, you're Marty." And they said, "Oh, you're Marty." And I said, "Oh, you're Marty." And they said, "Oh, you're Marty." And I said, "Oh, you're you were the most valuable person in Mom's whole disease process. You told us what to expect. So we would call, and Dad would say, this is what's going on with Mom. And they individually said, Marty said that would happen, so that's okay. Marty said that would happen, that's okay. I was amazed. I mean, I was quite honored, but sometimes it's really simple. Sometimes
Well, I think it's funny because it speaks to the idea of one of the scariest things about everything we've been talking about is dealing with the unknown. Like what's going to happen next month or whatever. And remember I mentioned the part about predictability and the idea that it tells you a chronology, and diagnosing early can help you be involved. People really get a lot out of having a sense and somebody saying, okay, so this is going to happen next, and this is what you might do about it. It's hugely relieving. So I can understand completely like why that would be such a benefit.
But it was quite amazing because these two people walked up to me and shook my hand and said virtually exactly the same thing. And so I thought about it with your brothers-in-law. You know, maybe they don't understand the process. I mean, you know, we talk about people who are like, oh, well, educate, educate, educate. Well, education is a two-way street. I can regurgitate information all day, but if you can't accept it and embrace it, then I'm not really educating you. So often, you know, it's share the information, sit with it a while. That allows us to process. We talk to other trusted advisors who reinforce whatever we've heard, and then we're ready to move. But, you know, that resistance and that denial is quite deadly.
I have a question, but I thought I'd just start with saying thank you. I feel I am immersed in this topic right now with two of my own parents and one mother-in-law, and I'm living the full spectrum. And I've been a little overwhelmed, and also avoiding one in particularly tough one. And you guys have made me feel motivated and able to tackle it. So I'm going to be brave. So truly, thank you. The aspect of, it's very individualized, but the aspect of that role of parent and child in switching, and particularly I think with my father, that's difficult. I am the parent. And trying to navigate that as the child of maintaining his dignity and respect, but also recognizing that that role is shifting. Any guidance on how to navigate that as the child?
How much time do we have?
20 minutes.
Ooh. I mean, that's probably one of the most central things, and the only comments I would make is some of it is not you, that, you know, we also have different capacities to accept that we are changing and that we are becoming more dependent or losing capacity ourselves. I personally have found that the parents who do best with it are able to accept that. It can't just come from the child saying, look, you need help and whatever like that. The parents that I've worked with who have been most successful are the ones who say, you know, actually, I need a little bit of help, and I know what you mean, and you're right, and whatever. That there must be some personal acceptance of our own aging and decline in capacity to do a dance with a child who is willing to take on more responsibility. And I think if it's, because I've also seen parents who have been asking for help and the children say, no, you're fine. You know, you're okay, you're fine. And they're trying to prop up and they think that, you know, dad's being depressed. And it's like, you're not listening. He's telling you a true thing. So I think it has to be kind of a two-way street where it's matching the change in the relationship as it turns. What do you guys think?
I have a lady right now that's a patient that's 91, and it's taken 2 years of us dancing. Little by little, she's let me in, little by little, I've had successes. She's got dementia, very poor safety awareness, but really quite intact, does great on all the tests. And just about a month ago was the first time she looked at me and she goes, this is a very bright, successful woman that lives up on Lakeshore Drive. And she goes, my short-term memory is for shit. And I'm like,
Yeah.
success! Now we can do some stuff. But it took her over 2 years to get to, I mean, we've got systems in place. It's not 100%, it's probably 80%, but that's better than 0. And so we've done this dance for all of this time. And she's now acknowledging that, so the next step will be 24-hour caregivers. She's okay with 12, and it will come, but it's taken us over 2 years.
My answer is The Driving Miss Daisy. Remember that movie?
Yep.
You're always the child. You're only helping your parent. You start by driving them a little bit, picking up some groceries, doing this and that, but you never stop being the child. You can't. If you try to flip that, then it all goes south. But if you just think of yourself as a child, helping out, excuse me, I'm emotional about this, helping out a little more, I think you're still a child. You're just doing a little more than you had to do last year. And it'll be easier for us because we've been used to our children teaching us how to use computers, right? So, and the remote and this TiVo thing, how does that work? Yeah, right. But I'm joking. But I think we sometimes forget that parents don't find it terribly shocking that we help them. It's not that big a deal.
Well, I think
In many cases. I mean, that they're used to the concept that they ask you for help, you help, and they're still the parent. And they don't see any change even though the help keeps expanding. And your father will still be the parent no matter what you do for him, and that's just good, and that's the way it should be.
maybe a way to think of it, there's a difference between a relationship and a role.
That one.
The roles may change, the relationship endures.
Right.
And finding ways to keep the relationship of parent and child, but to change the roles that are part of those relationships is the dance that you have to do. And it takes both sides to be able to do that. I have one that we didn't get to that I want to mention because I think it also goes back to some of Larry's expertise. If you have a relative under guardianship for financial reasons who's been giving away his money, and now health is declining, memory and lack of hygiene, which we can also touch on again. How do you move to assisted living, especially if he's resistant? Will assisted living facilities take people against their will? Can they turn you away? This goes back to suppose you have somebody who actually is going to say no or refuse issues of decision-making and consent.
Well, if you had that situation, if you don't have a power of attorney for healthcare decision-making, because typically that power is broad enough to deal with personal hygiene issues as bringing in care. But probably you need to expand the relationship of the guardianship to plenary guardianship, that is both property and person at this point, because the person is obviously declining. And again, as we go back to the first hour, the things will only get worse in terms of their cognition. So it's probably time to go to the court and say we need a full guardianship because this person is no longer taking care of themselves personally. Last time we were here, that wasn't the problem. This time it is. Once you get the full guardianship, then you ask the court for the right to admit the person to assisted living. The reason you might have the power, but you want the court's okay on that. And you explain why, and you should demonstrate why assisted living is the least restrictive way you can care for this person. It's just not possible to keep them at home anymore. Right. Then with the judicial okay, saying you are authorized to admit them to assisted living at some place, you then go to that place who you pre-screen and say, now we're going to admit my mother or my father. They're not going to be happy coming here. How can you help us deal with this admission of someone who is very reluctant? And the answer will be they should have systems in place that will help them deal with this. Now, they may have to go the pharmaceutical route where you have to get the person's aggressive behavior to back off, simply essentially drugging them up a little bit to get making more passive. But you're going to say no. I'm not talking about
I
total
suspected Barty was not going to like that.
but you may be, that may be necessary, may not. But often the person will be less resistant than they say. Once you actually at the door, they're like more like, it would be that would be your experience.
Right. And
I would do it differently.
Sure.
how would you do?
What I would do is I would look at the level of risk of the self-neglect. Self-neglect, not being able to take care of your daily needs, is often a sequela of dementia. If I were actually very concerned about that, I would take the person to the emergency room. I would talk to their behavioral health people, and I would do a non-commitment, an involuntary commitment to geriatric psychiatric unit to evaluate their disease process, start them on some meds, get them in a milieu that we can see what their behavior is and what's going on. And the drugs are still valuable,
You just put them on
but
meds,
they're
I thought we
they're
agreed.
being managed in a more dignified way.
Oh,
I would not.
Is dignified to be put in a psych ward? I don't think so. I think
Yeah.
I'd go for the guardianship and try to get a physician, see if we can deal with the problem with modest
You're-
intervention, if necessary, with pharmaceuticals, and I would try to avoid.
I would not take your patient in my assisted living because they're going to be disruptive when they get there, and it will totally make chaos of my whole organization. So I would treat them for their behaviors, which are in need of treatment. I mean, it wouldn't have to be a geropsych. They might be willing to go to a family practice physician for some medication, but I would not force the medication on them. That would be part of the treatment for their disease process. And
That's what geopsych ward can do, though. They can override resistance and force them to take psychotropic drugs.
no, we don't.
Well, yeah, it's a complicated thing because in a lot of jurisdictions and states, you can't use certain types of medicines involuntarily, that you have to go to court and do that. Let me offer a milder alternative and slowly back away in case there's fights going on here. But the idea of, interestingly, a lot of what resistance can be can relate to depression. And what's interesting from a medication standpoint is some medications used for depression, particularly in the elderly, that are of the Prozac type class, SSRIs. Interestingly, on low doses, when people are on SSRIs, it not only helps depression and mood, especially anxiety, but interestingly, there's evidence about how it affects the front part of the brain, and that actually people become less suspicious and more amenable and collaborative in discussion. So sometimes you can avoid the more severe sorts of things, including severe medications, by the use of SSRIs, and to start that and try that on an outpatient basis with somebody's doctor. And I've seen people, and it's funny, it's sort of brighten up and do better partly from the mood and decrease in anxiety, but actually become, I don't want to say more insight, but basically more aware and more workable in a way that really is nice. So that's an option that people need to think about.
Yeah, again, it depends on the situation. Now, if I've got someone who is kicking everybody else out of the house and refusing to take their meds and is defecating all over and urinating all over, so it depends on the severity of the situation. If this is someone that will take to a doctor and we can do an assessment on them and they're willing to take medications, that's one scenario. The scenarios that Larry and I are talking about are people that are quite impaired, and that we are really, really concerned about their safety and well-being. So there's a whole continuum here that we're talking about of more simple versus quite
More
significant. And
again, I think that
everything is someplace in between.
part of what we have talked about today is, I think we've tried to give you a flavor of the couple things that we have been saying, which is the complexity. We've tried to give you an understanding of the ambiguities and the fact that there are not clear-cut answers to some of these questions, that we've tried to give you a sense of the fact that you have to be embedded in systems, and there's multiple advisors and players of it, that caregiving and dealing with aging parents is a complicated process. But, you know, if you sort of educate yourself, know what you're doing, have good people that you are working with or that you can get involved, get good support, that there are possibilities that you may not have known about or been able to consider, and then just do the best that you can. Just do the best that you can.
And there is help out there.
Yeah.
There really is help out there. It can be a pretty isolating, scary place to be because it's quite overwhelming. But then lots of things in life are overwhelming, aren't they? And we survive those as well.
Yes, we do.
So, you know, you have a panel of people that I think any of us would probably take a call from you. Just within our network, we probably know other resources for you or can give you some creative solutions that maybe you didn't think about.
Okay. I want to thank our panelists. A lot of preparation and time on their part to be ready for today, so we appreciate it. And thank you to everyone for coming and for sharing your questions with us. And we'd love to hear your thoughts and feedback on our evaluation form. And please take the materials with you, and we'll look forward to seeing you soon. Thank you.